Yeah, thank you. Good morning. So I think please start the video of the first lecture. So good morning, everybody. I'm happy to be here again. My task is to talk about what's new in EUS and EUS F&A. I understand this mainly as diagnostic F&A and not so much therapeutic because there are further lectures. So I will mainly talk about diagnostic and only at the end have a few words on therapeutic EUS. No conflicts of interests with this lecture and the topic. And again, these are the three areas: imaging by itself, tissue acquisition by means of EUS, and a few words about EUS-guided therapy and what I think about it personally. EUS imaging has fallen short a little bit recently, meaning in the last 10 years. So the image quality of echo endoscopes has been developed pretty slowly as compared to transabdominal ultrasound. The circular echo endoscopes are considered old-fashioned and are hardly developed at all. A few companies still developing them, but there seems to be consensus that the linear type echo endoscope covers it all, especially with regard to punctures. As for imaging, of course, there are some extended imaging techniques like contrast imaging or contrast harmonic imaging, which is just an extended possibility of the latter. Elastography, etc., have been introduced and tried in studies, and there have been contrast agents. Basically, imaging studies in endoscopic ultrasound as well as in other areas are often difficult to really put into clinical reality. There are methodological flaws and problems. There is a great subjective element of the examiner, so you are more testing the examiner who is unblinded than the echo endoscope, and therefore, at least in the initial so-called honeymoon phase, EUS has been overestimated. This was like 25 years ago, where we had brilliant staging results in all areas, luminal, pancreas. This has slowly been given up in many centers. That's at least my impression. And there was also a recent paper showing this. So I think there is not enough emphasis, and people have largely embarked on biopsy and also therapy. It's actually a similar tendency like in conventional endoscopy. You know, initially everybody was extremely happy with the new images you got, and then, of course, there was biopsy, polypectomy, and therapy, and but by and large, imaging became better and better in the second run, and now endoscopic imaging is actually brilliant, perhaps helping the introduction of artificial intelligence into the diagnostic area. So I'm hoping at the end that with ultrasound, endoscopic ultrasound, there might be a similar tendency in the future. So here you see the two techniques in the pancreas. On the left side, the application of contrast with harmonic imaging, which helps to further characterize lesions which are just echo poor on the left side and more differentiated, like cystic, partially cystic at least, and partially solid on the right side. Elastography, which depends on experience and subjective impression and interpretation of the examiner as well. So it's not a fully objective technique. It measures the hardness of the tissue and was enthusiastically welcome at the very beginning. Now it has sort of faded away a little bit, but also provides additional information. So of course, there has been a long-standing history of using ultrasound images for differential diagnosis, and we all, in our early days, have been publishing on the pancreas, pancreatic tumors, differential diagnosis, very difficult. And this remained so. Initially, brilliant results, but then we realized, if we don't really know, and if it's a difficult lesion, then the imaging technique is not very reliable either. Whether this might change in the future with artificial intelligence is really interesting. I don't know. I'll come to that in a minute. But there's also another interesting use to use EUS imaging for guided puncture. And there are different possible areas, like if you have several lymph nodes, so maybe you select by imaging that one which has the highest likelihood of being malignant, and you puncture this one. And the same might be helpful full in pancreatic tumor puncture. You select the areas which look the most malignant ones, and then you target your needle to get into that specific area. There have been very few papers on that. In fact, there are, of course, a lot of papers, even in recent years, on differential diagnosis, like here on lymph nodes, but not in conjunction precisely with FNA. So this is one of my beloved meta-analysis, 4 studies, randomized trials, or controlled trials, 336 patients. Sensitivity 82%, false negatives a little bit less than 10%, and contrast harmonic EUS imaging was slightly better. So there is still ongoing activity in having differential diagnosis of lymph nodes. In fact, these studies are greatly hampered by the difficulties in really identifying that very lymph node on a later surgical specimen. Some of those studies help themselves in puncturing that specific lymph node by EUS FNA and therefore trying to get a more reliable gold standard. But this is not an outcome study with regards to FNA, and I didn't find any other. Actually, the only one I found is this one, and they use contrast enhanced versus standard imaging for EUS FNA in solid pancreatic lesions. So that's a good study, outcome study, randomized trial. On one half of the patients, you use your highly sophisticated imaging and select the areas and do your puncture guided by imaging, and in the other, you just use the normal imaging. And as you can see, there was no difference basically in those 148 patients. Sensitivity was very slightly higher, of course not statistically significant. To reach a statistical significance in that area, you need 1,000 patients or more. And false negatives were also equal. So disappointed hopes. Maybe other groups do better, or again, artificial intelligence helps. And therefore, for imaging in general, I still think we have underrepresented areas. So EUS imaging is maybe too much neglected or underused. For example, luminal cancer staging. I think there's a great need. So we have all kind of neoadjuvant protocols, and people try to figure out which tumor stages benefit most. So whether you really have to pre-treat a T2N0 cancer in the esophagus by neoadjuvant radiotherapy, or whether you have to rely on lymph nodes. EUS for cancer staging, although it has been kind of forgotten, is still the relatively best method. Although some papers in the last 10 years have shown it's actually not doing very well in the clinical practice. It is still better than CT, but if under serious clinical conditions you compare EUS with CT in luminal staging and especially in lymph nodes, EUS actually does badly and CT does miserably. Also, submucosal tumor diagnosis, it's still the same thing when I started EUS some 35 years ago. So we have the tumor, we think, okay, it could be this or that, and you could do follow-up or not. So I think there is a clinical need which we have not been able to fulfill in the past, but this doesn't mean that this should not be possible in the future. And maybe we put too much hope on artificial intelligence, but I'm deeply convinced that it will come. However, it really requires a meticulous development of images, videos, recording. You have to have a very good gold standard. So maybe FNA is not enough in SMT, especially. It has been fared badly in recent studies. So if you do it well, if you have a proper histologic gold standard, I think artificial intelligence might be helpful. And it's my personal help that it will give a slight push to EOS imaging, which should not be, as I mentioned, like in luminal endoscopy, totally forgotten, even if FNA and therapy is much more interesting. And so for tissue acquisition, I think it's very simple. Here you see FNA, and this is what I want to have, not only blood, but also tissue. And it's very difficult up to now, you know, you have to put the tissue into fluid, and then you fiddle around and take the pieces out and look at it and assess it. And we have different needles, and we have more than 150 randomized trials, but we haven't become much smarter. So this is the current needle design, this Charcot type of or bifocal needle, which was said to be much better in getting histology. My strong belief has always been I'm not so happy with cytology. There are great variations. There is no really established second opinion process. So histology is the way to go. And it seems to be that this slowly arrives in the endosonographic community. FNB, fine needle biopsy versus FNA, fine needle aspiration. And there is another recent one of my beloved meta-analysis comparing the two. Actually, EUS FNA is the area where we have the most randomized trials and most meta-analysis, more than 50 in the meantime. But this compilation of studies shows that FNB is slightly better. Although the problem with all those studies is what exactly is histology, and do we measure histology or diagnostic accuracy, and what do we use for that, histology, cytology? So basically my wish and hope is it should be like endoscopic biopsy. So you take your biopsy, you put it into formalin, and goodbye. You don't fiddle around with a specimen, you don't smear it, you don't smell on it, you don't look at it. It's the job of the histopathologist, and this is my hope that EUS FNA, or more precisely EUS FNB, should be. So finally, a few thoughts, a very personal opinion on EOS guided therapy. I think it's pretty much established in the drainage of fluid collections, mostly around the pancreas. We are dealing with cysts, we are dealing with necrosis, necrotic collections, and EOS provides a perfect access. And there are the current discussions center around which stents we should place, what should we do? Should we just drain and maybe flush, or should we remove debris and necrosis? So what's best for the patients? And we're waiting for further randomized controlled trials. Another more recent and very interesting application, which was based on the development of new yo-yo stents, is the creation of anastomosis or accesses, gastroenterostomy for tumor palliation, perhaps for obesity in the future, gallbladder drainage in a few inoperable cases, and biliopancreatic. It's more access than anastomosis or drainage. This is a difficult area because there are so many accesses, especially to the biliary duct. It's through the liver, it's into the CBD from the duodenum, it's rendezvous, it's permanent drainages, etc., etc. So it's still not established, but I think we are mainly suffering from the insufficiency of the accessories. So we still have the needle and a guide wire, and this is not a very good and subtle combination to maneuver the guide wire to pull it back, etc. So there is an urgent need we have been telling to companies for more than 10 years to develop, and then this will flourish. And then finally, we have a few niche indications. Celiac plexus neurolysis is popular in some parts of the world. Interesting reports about vascular access and therapy. There are alternatives, whether we need it, whether TIPS should be done by means of EOS or the established way, I'm not sure. And unfortunately, tumor injection therapy has not got off the ground. This is the most fascinating theoretical application, but we have not come any further that it has entered the therapeutic space. But I think we'll hear a lot more in the coming presentations. So thank you very much.
Thank you, Thomas. Very sophisticated presentation. First of all, I'm sorry it's not to introduce you. Great Professor Thomas Rosch. Sorry. Okay, let's move on to the discussion. So I have one question. So apart from USFNA technique or the accuracy, and the needle is very improving now, but scope, in terms of scope, endoscope, there's almost no change from the many years ago. So how about the idea? Do you have any idea to change the good US system or scope?
You mean for FNA only or for imaging?
Yeah, both.
Both. I think imaging, I try to stress that imaging is greatly neglected. And we have huge progress in, CT, MRI. It's really fascinating. We have very good progress in transabdominal, but people seem to think, well, a primitive image is enough to put a needle in. I strongly disagree. I think this should be developed further. And if we ever want to enter the field of artificial intelligence properly with EOS, then I think imaging has to be improved. Basically, the technique of FNA with the channel and the instrument design is okay. I think for most indications we get along, but so I think there should be a major emphasis on imaging.
So how about the good scope for USFNA?
You mean the good scope?
Yeah, scope. Echo endoscope for USFNA.
Yeah, well, I think there is not so much need for improvement in the scope design for FNA. We have been trying forward viewing scopes for FNA. There were a few studies. By and large, it was not superior. It might be helpful for a few indications. So in the ideal world, you would have both, for example. But this has been too costly. So I think it's more imaging than the scope. And of course, it's needle design. So I can't understand if you, again, an endoscopic biopsy, you open the forceps, you take the specimen. With the needles, there are at least 10, 15 different techniques, fanning, how you pull, whether you suck or etc. So it's hard to understand why it should not be possible. Put the needle in, there is tissue in the needle, pull it back, maybe by freezing or whatsoever, and put it into formalin. So that should be the final stage.
Okay, thank you so much.
Just Thomas, and then I will let the floor to Takao for his talk. Thomas, one question. I know that you like very much negative studies, okay? You enjoy this. What about mini probes and EOS mini probes? They have been very popular, and it seems that they disappear now. Despite, I think in Japan, they are still using them. What do you think about mini probes?
Well, the technical development was stopped. By the way, I sometimes like negative studies, but if there are too many, I start hating them. The mini probe has the charm of easy applicability. Everything else was not so good. So they broke easily, especially if you put them into the bile duct. The imaging, the depth of penetration was limited. I think for if there was a huge technical jump, then the mini probe would be an easy solution for at least maybe 50% of the indications like luminal. But at the moment, with the current stage of development, which is 10-15 years old, I don't see much room.
Okay, thank you very much, Thomas. Now we will move to the next presentation by Takao Ito.